Hey there. Yes. Ready? All right. Here we go. All right. My name is Kelly Scaletta, and you are watching the Punch Show. And today I'm here with Dr. Steve Schwab. He's a professor at UTSA, and he's specialized in uh, healthcare economics. And so he's here today. We're going to talk about how things are in America and what some of the different theories are and ways we can improve it and things that are good with it and things that are bad with it and so on. So anyway, Steve, do you want to just give a little more introduction of yourself? Like why should people listen to you?
Sure. So I've got a couple decades experience in healthcare. So I'll give you sort of my background story that when I was in college, I became an EMT, did that for a little bit, really got the certification, didn't do a lot of work in that. I was actually in ROTC, joined the Army after college as a medical service corps officer, ran medical operations in Iraq for a few tours. Came back, was ready to get out of the military, and they asked me if I wanted to go get my master's. And whenever you have somebody else that's willing to pay for your education, it's good to think about it.
Always
So
a
I
good
went and I went to Baylor University and got 2 degrees. I got a Master of Business and Master of Health Administration. Went back to the Army after they paid for this, and ended up as the Chief Financial Officer of actually DoD's largest biomedical research institute. Did that for a little bit, and then again got the military to pay for some education. Went to University of Pennsylvania, Wharton School of Business. Got a degree, a PhD in applied economics with a focus on healthcare management and economics. Um, Went back to the Army, did some teaching for the Army for a little bit, and then was ended up as the chief financial officer of the military's largest hospital, only level 1 trauma center. And what's important is this particular military hospital, unlike most, also sees civilian patients, also does billing, deals with insurance, really typical healthcare operations. Did that until I hit 21 years in the military and decided to call it a day, and then was able to transition. So now I'm a professor, as you mentioned, at UTSA. I'm also an adjunct professor at Columbia University in their Department of Health Policy and Management. I teach executive MBAs at UTSA. I teach executive Masters of Public Health and Masters of Health Administration students at Columbia. A lot of these are clinicians or others in the healthcare space that really want to understand more about the business aspects. I've also published in top journals, from Science, which is one of the sort of top scientific journals, to top policy journals, Health Affairs, Management Science. And so I think I've got a fairly good hold on what's going on in our healthcare system.
I would hope so. But are you proud to be a fellow alum with Donald Trump?
I'm not sure pride is the feeling I would put on that. So I'll just say, because I think politics may come up here a little bit as we're talking about that. I'm pretty centrist, right? I voted Republican, I voted Democrat.
Right.
In recent years, I am not voting Republican because of I don't agree with sort of the Trumpism movement for many reasons that we could get into. I know that's not why you asked me to come on here, but I will say that my positions are either very center, or you could say that they piss off both the left and the right. So, however we want to look at it.
If you're pissing off everybody, you're usually right about something.
Yeah.
So this is actually a question you'd ask me to ask, and I think it's a great question because I think we tend to a lot of times just jump right into negative things. But you wanted me to ask, what are some good things about our system currently?
Oh, sure. Yeah. So I think the US has the best system money can buy, right? So if you are in the upper distribution of wealth, you can get really, really good care in the US, and I would put it up against or better than anywhere else in the world. We also have a tremendous amount of innovation. So, I know we're gonna talk about other countries and how they pay for drugs and how they pay for innovation versus what the US does. But the US is really subsidizing the world's innovation. So things like GLP-1, right? So Ozempic, you hear about these wonder drugs that come out.
Right.
Well, that comes out a lot because of what we're doing in our country. My son had a bout of appendicitis last week and had to have his appendix out. I had my appendix out about 25 years ago. I was basically bedridden for weeks, right? Able to get up a little bit, but really, really painful. My son was out of the hospital the same day as the surgery, and then
Laparoscopy
back
or
to school. What's that?
laparoscopy?
Yeah, he had laparoscopic.
That's what I had.
Uh,
That's what happened with me. Yeah.
oh, okay, yeah, right. But this didn't exist years ago,
Yeah.
right? These are medical innovations that they've reduced readmission rates, they've reduced infection rates, they've led to much easier post-acute care. And so, we've got a lot of innovations going on in this country, and we've got a lot of really good healthcare and really good physicians. No, we've got a lot of problems too, and I know we're going to get into those, but I think it's worth thinking about the advantages that we've made both on a medical innovation and on a public health standpoint, things like the Clean Air Act and clean water. And if we go back, 100 years, like we've really, really introduced systems that make the world a better place, both for those in the U.S., but also, across the world.
So just to sort of add to what you were saying a little bit, I got my laparoscopy. I got my appendix taken out about 20. Well, actually, it's maybe 35 years ago, and it was a cutting edge process. Like it was brand new. They were still, like I think it was still in the experimental phase. But I happened to be in Rochester, Minnesota, and I had it taken out at St. Mary's Hospital, which is part of the Mayo Clinic. So I definitely benefited from having what you're describing, which is access to this cutting edge technology that's way ahead of the rest of the world sometimes. So
yeah,
like
that's
you
pretty amazing.
Yeah.
I had an open appendectomy and it was painful. I remember waking up in more pain than when I went down.
No, I was at home the next day. It was I long story, moved to Minneapolis the next day, but I didn't have to do any of the moving around stuff, just me. But
yeah.
So anyway, based on that, and I think this leads in nicely to the next question, which is we've talked about this subject before in general, and you mentioned trade-offs a lot. What do you mean by trade-offs, and what are some of the trade-offs?
Sure. So it's really hard to find things that make everybody better off, right? And so what we want to think about is if we adopt a policy or change something, what are we giving up to get it? And you could think about, right? I'm a coffee drinker, right? I go to Starbucks or wherever to get my coffee. I give them money and they give me, right? There's a trade-off, right? I'm paying a price. Now, hopefully I value that coffee more than what it cost me to get it. But now in a healthcare range, right? We think about a couple of different models of healthcare. Sort of the dominant one for many years was called the iron triangle. And it was the idea that we have 3 points of the system. We have cost of the system, we have access to the system, and we have the quality of the system. And if you're going to improve on one measure, if we want to improve the quality, then either we're going to limit the access or we're going to increase the cost. And again, for many years, we felt there was no way around this, right? These are the trade-offs. Now, in more recent years, we've thought about, okay, well, maybe there is a way to sort of expand the pie. Maybe we can improve quality and not increase the cost. And things like focusing on preventive care, right? Keeping people from getting sick in the first place may increase sort of quality when we think about a population level. And, I think most people, rather than getting, a great appendectomy, would just rather not need it, right? Not get appendicitis in the first place. And that's cheaper because then we don't need to care for you. Now, some examples of trade-offs, because I think you're going to probably ask me about Medicare for all or single payer. And example, when we think about insurance, we think about two primary problems. And both have to do with the fact that information, like you and I both don't know the same exact information. And so one side of this is what we call adverse selection. And it's that insurers don't really know who's going to use a lot of healthcare and who's not, right? So leaving aside pre-existing conditions and all that we'll get into, you worry that the people who are willing to spend more money and have a better insurance policy are the people that are sicker or likely to be sicker. right? You might think about, even if you're thinking about young people, if a young couple is planning to have a child and they don't have health insurance, they know it's expensive if you have to pay by yourself to have a child. And so that's the time when they're incentivized to go buy their health insurance.
Right.
Right. And so you end up with, this raises the cost to everybody in the program, because the people that are getting it tend to be on average sicker, which raises this average cost, which means the healthier people that are having insurance might say, you know what, it was worth it when it cost me $500. It's not worth it if it cost me $600. And so they sort of drop out. Now that raises the average cost for everybody. Now, a way around this is we just give everybody insurance, right? Single payer. You don't have to worry about sicker people buying insurance if everybody has insurance, right? Now you no longer have this adverse selection problem. You've solved it. But on the other hand, you worry about what we call moral hazard. And don't get caught up in this moral. This is a term from the 19th century, when people felt like this was a moral issue. But in today's age, we think about this more as incentives. But if you're not bearing the cost of care, let's say that you have zero copay, zero coinsurance, and you feel a little sick, you're probably going to go to the doctor because there's not a real cost to you. If you have to pay something, even if it's small, you might say, well, it's the sniffles. I can wait a day and see if it gets better on its own. Or you might say, you know what, I can wait tomorrow to get into the primary care physician. I don't need to go to the emergency room now. And so we worry about this idea that people, I don't want to say, I don't like the term overutilize, but they utilize more care than they would if they were bearing the cost of the care, is really this idea. And what that means is if you give something like single payer, and again, we'll get into the details of it, I think later, but you're going to end up people are going to use more care. And that's going to end up raising costs, because some of that care may not be worth the value to the consumer of what we're actually paying for that care, right? So if you say, hey, even if you're well off, you might say, hey, $10 to go see the doctor or wait a day, I'll just wait a day.
Right.
Where if it's free, you say, hey, I'll take it, right? It's free. Sort of like the
Well,
buffet, right? You go back for that like extra serving on the buffet.
Isn't there like another side to that, though, that like somebody says, I'm not feeling well, I don't have the money to go to the doctor, so they put it off. And then 2 weeks later, they're really, really sick. And then they go to the hospital and it turns out they have leukemia and they don't have insurance. And then the hospital ends up having to write that off, but that gets still put onto the people eventually by transitory properties. The people that have insurance end up paying for it, right? So like,
yeah, totally.
Isn't
right.
there like
yeah,
the counter to that? Like,
yeah, absolutely. Right. So we worry about, again, like, is it, we worry about both underutilization and overutilization, right? We don't want people to use it unnecessarily. At the same point, we want people to be able to use care when they need it, right?
Okay.
So, and this is this trade-off. Like, how do you find the right point where we discourage people from using care if it's not worth the money that would be paid for it, right?
And with your experience in the military, I know when I was in the military and I worked in a clinic, and we'd have people that would come in every time their kids got the sniffles, and it was like the same, 8 kids almost that were always using all the doctor's time. And so like, this is not a hypothetical situation, right?
No, not at all.
We like, it's not just somebody that is against this is just making up these excuses. These are valid actual.
No, absolutely, right? And again, it's the difference might be not that we don't want people to use care, but do we want them to get in the right setting of care, right? So if you need to see your primary care doctor, going to the emergency department is really expensive. And again, we could talk about why it's really expensive. But there's capacity constraints. And now let's say that you're the person that really needs emergency care, and you've got 18 people that are there with the sniffles. Well, yeah, we try to triage and get people in at need, but you can't do that perfectly. And so now you've got people that really need care not getting in. And I'll give an example. I have a cousin that died while waiting in the emergency room, right? He had kidney stones, which I think we generally don't think of as a life-threatening condition. But I think it was something like 8 or 9 hours. He's sitting in the emergency room. He was, I don't know if I would say in poverty, but he was a very sort of lower income individual. I believe he had Medicaid. He may have been uninsured. and he's sitting there waiting to see the doctor. But because these safety net hospitals end up with so many people in them, he ended up waiting so long that he ended up passing away. Right.
Wow.
And this is,
Uh,
yeah, like a terrible situation. And so now, is that because people are coming unnecessarily? I'm not saying that at all. I don't know, who was in the hospital or in the emergency department that day, but we certainly worry about capacity. And we
mhm.
only have so much room in emergency departments across hospitals, especially when you come into more rural areas, like where this occurred, in rural Louisiana. And if we fill up those emergency departments with things that aren't needed in the emergency department, then we create this problem where people can't get in when they do have an emergency.
I
And again,
agree.
our ability to triage is not perfect.
Mhm.
So
That
anyway,
makes a
long
lot of
story to
sense.
say,
Yeah.
like there's like these are complicated issues. And
Mhm.
if it was like clear one thing's going to solve it and it's going to make everybody better off, I think, for the most part, I mean, there's certainly some politics to that, but in general, we would do it. But most policies are going to have give and take. Even if you might say, okay, well, you get a lot for what you're asking for, you don't give up very much. That's fine. That's still a trade-off we need to think about, and then we can make a decision whether we think that trade-off is worth it.
So you might maybe a compromise or something would be, like copays, like
Mm-hmm.
universal healthcare, but
Mm-hmm.
a $30 copay, and then if you're, um, like maybe find some ways to mitigate that if you're super super poor, but you know, um,
Sure. Yeah. I mean,
like
we also, yeah.
those are the discussions to have, right? Not just absolutism.
Exactly, right. So what's the right level and what are the trade-offs? So let's say that we want to put in a policy and we think we can pay for it with a wealth tax on billionaires.
Hmm.
The average person may say that's totally fine, right? I'm not worried about Elon Musk and whether he can pay his bills, right?
Right.
Let's leave aside the macroeconomics of investments and all that for a second. You may just say, hey, I don't really care about those people. It's a relatively small price to ask them to pay. But it's still a trade-off. And so we
Hmm.
still need to think about, like, what does that mean? Because we search for what economists call Pareto improvement. Pareto improving means that it makes at least some person better off and doesn't make anybody worse off.
Hmm.
There are very few Pareto improving policies. Most policies will make somebody worse off. Now, again, that might be a very small price to pay for somebody that can handle it to make a lot of people better off. In which case, I think we'd say, okay, that's worth the trade-off. Other times, it's going to be much more 50-50, or maybe even 30-70, in which case say, okay, it's not really worth that trade-off. But we got to be really cognizant of making these sort of analyses to say, okay, what's the trade-off that's required? And is that trade-off worth it? And that becomes a sort of subjective decision to say, is this worth it? And that really goes into more of the political realm and outside of the economics realm, where we're able to tell you, okay, this is the actual trade-off, and then let people who want to make those subjective, ethical, moral decisions say, okay, this is worth it or this is not worth it.
So this is, I think, um, leads us to the next question, and I, based on what you're saying about trade-offs, is universal healthcare a feasible goal in America? Do you think that's an achievable goal? Is it a realistic goal? Is it
Sure.
um
Yeah. Yeah. Um, so this is interesting. So I'm going to go back to, like, I don't know if you ever heard about the SMART goals, right? So this is specific, measurable, achievable, realistic, and time driven. So when we're setting objectives for, say, employees, we want to think about setting these. Well, if I'm going to put universal healthcare in that, first of all, I want to know what universal healthcare means. And many people think about that as single payer, right? That the government provides
mhm.
it. A universal healthcare, it definitionally just means that everybody has health insurance. Everybody
Right.
has access to it.
That's what I mean by whether it's private or public or whatever, that
Yeah.
everybody has it, that and nobody, whether you're
Yeah.
poor or rich or whatever, you have access to healthcare you need.
Right. So measurable, right? So 100% of people have healthcare. Is it achievable? I would say yes. I think this is achievable. I think it's realistic. The question really comes to the time driven, right? So
Mhm.
how long will it take us to get there? I will say that I think there are some fairly straightforward policies that we could get to universal healthcare, based on the existing infrastructure that we have. Now, if you want to talk about going to a single payer or Medicare for all, I think that's a much more difficult conversation simply because we don't have the infrastructure in place for that. I mean, there's some other reasons that we may or may not want to go that route. But in general, right, if you're going to say, okay, everybody in the health insurance industry, you're now unemployed, that's going to be a massive change to our society. Now, we've gone through massive changes, right? We've gone through the Industrial Revolution. We've seen major changes in manufacturing. And so it's not to say that it can't be done or that we should pay for something just because people have jobs in that. We could think about retraining. We could think about, like, there's probably some jobs to still administer this, but it's a much more difficult transition than if we think about a universal healthcare in our current infrastructure. But I do believe that is achievable in that the ACA was designed to get us to universal healthcare. Now, it has not gotten there. We still have somewhere around, depends
it was
on
like
the
a
number.
stepping stone, right? Even like Obama would say, it was not the final goal. It was to get us to a place where
but I think it's also important to remember that there were some laws that were passed or some regulations that were passed along with the ACA as part of that were later removed, either legislatively or by the Supreme Court. So one was that the Medicaid expansion, right? Mm-hmm. So there are many states, I have to check, I think it's 13 at last count, that is still not expanded Medicaid.
And those are mostly red states, right? Like deep red states.
Yes. I believe all are deep red states that have not, right? It became increasingly politicized. Well, I don't know increasingly, but it became very politicized about Medicaid expansion. And so a lot of the currently unemployed are on what we would call this sort of working poor. The idea behind the ACA was that basically the poorest of America would be covered by Medicaid, the traditional Medicaid as it already existed. And then you would have this group that's sort of this working poor that would be covered by Medicaid expansion. And then as you get slightly wealthier, again, we're not talking about people that are particularly well off, they would be able to go into the ACA exchanges. And what happened is that you end up with this group that are too rich for Medicaid, and I use the term rich meaning over their limits, not rich in the sort of common sense, but too poor for the ACA exchanges. And so these people are really just being left out of the system right now, where they're not eligible for ACA subsidies. They can't get a policy through that because they can't afford it. And yet they're not eligible to be on Medicaid. This is a major problem where we are in Texas, that, Texas is not a Medicaid expansion state. Texas has one of the most stringent Medicaid programs in the country. And so you have a lot of people that are not able to get coverage simply because they're in this like donut hole of too wealthy for Medicaid, too poor for the ACA.
That actually, if I can, that brings up a question I think that I had never thought of. But when we talk about like expanding to universal healthcare and things like that, but we live in a federal government with state governments where state governments, they have their own, like rights, whatever that means. But does that make it harder to have a nationalized system, having all these state governments where they might not want to go with a nationalized system?
That's a good question. I would to some sense defer that to a political scientist. My opinion would be that it creates complications, but it doesn't stop us, right? So we've got a lot of things that are nationalized, even though we have state governments, right? I mean, we have lots of national regulations over lots of areas. The whole country, we can talk about different levels, but basically the entire country has access to a public school system. Now, again, the quality of the school system varies by not just by state, but even by local district within a state. And some states have vouchers and school choice and all these other things. But we've managed to have consistent infrastructure across many things, transportation, railroads, roads, whatever it is. So I don't think it precludes us from creating this. I think the politics makes it more difficult But some of that goes into, we have a first past the post system, meaning if you get 50% plus one of the vote, you win your seat, where many other countries have proportional representation. So if you got 30% of the vote, you get 30% of the seats. And
Right.
so that really creates like a different dynamic in the US than it does in other countries. Clearly, the Supreme Court ruling and saying that Medicaid is, a state's choice changes the dynamics on what could be passed by the federal government. But I don't think it means that it's impossible, but it is something that we have to work through.
And then I think I accidentally redirected you, but you were talking about some of the issue that they had taken away some of the things in the ACA. Did you want to mention individual mandates?
So the individual mandate was never really very effective to begin with. So one of the things that the Republicans under Trump did was they didn't actually get rid of the individual mandate. This is a little bit semantics, but they set the penalty to zero. So under the original ACA, you were going to pay a penalty, and it scaled over years, but you were going to pay, say, $600 if you didn't have health insurance, right? One of these like minimum viable plans. And so what the Republicans did is they said, okay, you still have, like, by law are required to have health insurance, but if you don't, there's no fine for it. And so essentially they get rid of the mandate, not completely, because some people still see that on their, when they're doing their tax returns and don't want to be in violation of whatever the law or regulation is, or perhaps inertia. But the challenge is that the actual level of the penalties was never really high enough to induce many people to buy insurance. So if you're talking about an insurance policy that could cost, let's say the average family of four insurance policy, now this is on the employer sponsored market, is about $22,000. A $600 penalty is not enough to get you to spend that kind of money. Right. Now it's going to be less because of subsidization and all these other things. But it's just not enough to really induce many people to buy. And the latest research says, based on what was seen in Massachusetts under Romney Care, is that really, if you want to induce people to buy insurance, you need a penalty that's about 25% of the premiums that you would want, which is going to be significantly more than what was under the ACA as passed.
So like $5,000 instead of $600.
Yeah, exactly. And so I don't think like it really did very much to have this mandate. There were good reasons to want a mandate. We want healthy people to enter the market, because the way insurance works is that the healthy subsidize the sick, right? You got the healthy people that are putting their money in, and then, because we don't actually know when we're going to get sick. And if you do, it's there. And we can tell you this with probabilities, right? This percent of people are going to get sick, but it's really hard to say that it's Steve Schwab or Kelly Scaletta are going to be the ones that get sick. And so, but you and I know a little bit private information, right? Like, I know if I'm skydiving every weekend, but the insurance company doesn't really know that. And so what we want to do is get the people that are going to be healthy, maybe unobservable to the insurance company, to put their money in. And that's what the individual mandate tries to do. It makes a lot of sense. However, it doesn't seem to have made too big a problem. Like, getting rid of the mandate didn't destroy the ACA. Would it have been stronger with a stronger mandate? I would think so. But I also think that it's politically untenable to have that level of a mandate, given that that was one of the least popular parts of the law. And Kelly, I think you froze.
Can you hear me?
Yeah, now I can.
So looks like we just had a boo-boo, but it's all right. You were talking about the individual mandate.
Yeah. So I'll sort of rehash a little bit quickly that the mandate never was very effective because it wasn't enough. and it was also the least politically supported part of the law. So while I think the ACA would be stronger with a stronger mandate, it's not really clear that that would ever like pass the level of mandate that we would need. So I'm sort of fine with leaving that. I don't think that had any major impact. I think the bigger change was when the law was passed. You had this piece of the law that said, "Hey, if you're an insurer and you lose more than something like eight, like you have some estimate of costs, right? And if those costs come out at more than 8%, that higher than what you thought, so you're at 108% of the total costs, we're gonna subsidize some of you, right? We're gonna help stabilize the market. And if your costs are low, you're gonna pay some money in." Now, the idea is that this would be somewhat budget neutral, that the sort of winners would pay off the losers. But there was this exception that allowed the government to step in and make sure, right? It didn't have to be budget neutral. Well, Marco Rubio comes up a couple years after the law gets passed, and he really says, "Oh no, this is a government bailout of insurers," which is a very it's not a bailout in the sense that we think about what happened in the Great Recession and other bailouts. It's not necessarily factually wrong, but it's the wrong sort of discussion of it. And the challenge is, if you are an insurer in a market that we've had insurers in for many years, it's not so hard to sort of think about, okay, what's going to be the average cost of a person, right? So if we're talking about Medicare, we kind of know what's the average cost of a 65-year-old with whatever, right, that lives in rural Kansas.
Right.
But the ACA was opening a market of people, that had never had insurance or largely had never had insurance. And so there was a lot of uncertainty about like what's the right level of premium and how much is going to be paid in healthcare costs, especially when you have people that may not have had access to healthcare for many years. And so there's going to be what we call pent up demand, right? They're going to need to go get taken care of, right? Like you talked about the person who goes in and delayed care for a couple of weeks.
Yeah.
Well, now think about that on like a year's basis.
Yeah. So somebody that's got high blood pressure for 15 years and never been on a medication for it.
Exactly. Right. And so there was just a lot of uncertainty that was in the market. And the reason that these risk orders were put in was to say, okay, we know that this is uncertain. We want insurers to enter this market, but if it's so risky, insurers are not going to enter a super risky market. They're gonna stay in the areas where they have really good actuarial tables, right? That they can kind of predict really well. And so the government said, okay, we're gonna have the stabilizing effect, and so that if you lose a bunch of money, we're gonna let you lose some, but we're not gonna let you lose enough that's gonna like completely destroy all of your profit.
Yeah,
right.
Gotcha.
And if you do really well, you're going to help us offset those that did, right? So if you're way overestimating your costs and you come in and you did really well because you got, right, these people end up costing way less, you're going to help us offset that. Well, Rubio says this needs to be budget neutral, right? That the government cannot step in. That gets passed, I want to say 2014. And what happens is a bunch of insurers lose money. That the average costs were higher than what they had estimated. And you get lots of insurers leaving ACA marketplaces to where you've got lots of areas that only have one or two insurers. So now all this idea of having competition in the market doesn't really exist because you don't have enough insurers in the marketplace to create the kind of dynamics that the exchanges were designed to create. And oh, by the way, the rest of the story is that the Supreme Court rules years later that we had, even despite this law that said it had to be budget neutral, because the promise had been made previously, we still had to go and send these checks to the insurers that lost money. So not only did the US still end up spending the money out of tax dollars to offset these losses, but we also got this negative effect of insurers leaving the market. And so that is one of probably the biggest impacts to me along with the Medicaid expansion that really kind of destabilized the ACA. Now, the ACA has done a lot of good things. Our uninsured rate is roughly half of what it was before the ACA, right? And then you can think about things like the prohibition on pre-existing conditions. So if you think back to, just not that long ago, 15 years ago, if you had a pre-existing condition, so let's say that you're working, you've got good health insurance, and you develop a heart condition. Good luck changing jobs, right? Because if you lose that insurance, nobody else is going to insure you. Or if they are willing to insure you, they're going to charge you an astronomically high rate that you might as well just not be insured. And the ACA created, in addition to creating these exchanges, said, you can't do that. We're going to limit it, right? You're not going to be able to do what we call experience rate, which is charge someone based on how sick they are. You're only going to be able to charge them based on a couple of factors, right? So where they live, do they smoke, and to some extent on their age, right? And then we're going to limit you can only charge, say, older people 3 times what you charge younger people. Right. And so there's some limitations on this. We do allow a little bit, but this is what we call community rating. You need to come up with
you're like, if you're in a higher risk pool in a general way or a lower risk pool, your premium might change, but it's not, well, you had cancer 25 years ago, so for the rest of your life, you have to pay 5 times as much.
Exactly. Right. And so there's some really, really strong parts of the ACA. The ACA is a really complicated law that created a lot of things. And, it changed some of the way we pay health insurers. It created what we call accountable care organizations, which are combined groups of different providers trying to think more about population health. But the actual exchanges have really suffered from these changes in the laws that occurred. And we still have, roughly 10% of our population that don't have insurance, based on the fact that we've not created the infrastructure to allow these people to be able to get insurance.
So now, connected to this, and I know you're not into the political end of things, but Donald Trump has been talking about repealing the ACA. And, he's got a concept of a plan, apparently. And they nearly did it. If it weren't for John McCain, it would have already been repealed. What would happen if it just got sucked out one day and there was just no more ACA? What would happen to our healthcare system?
I can't explain how detrimental that would be, right? So not only would we go back to where we were, right? So now we're going to, at least double our uninsured rate, probably higher because people have moved into the system, right? There's some, hey, maybe I had a choice, but like I moved into the ACA, or right, employers, especially if smaller, have said, okay, we'd rather you be in the exchange. It's too expensive for us to offer this. Now there's some limitations if you're a big employer to do that. But you're talking about taking a giant step backward in a place where we've prepared for today, right? People have made decisions based on today. And to me, it'd be like, if you got rid of grocery stores. Well, yeah, did the world exist before grocery stores? Sure. But we had much higher mortality rates, right? So let's not pretend like it's the same world. But also, I don't know how to go slaughter an animal and create because I haven't had to do that because I've lived in a world where I can go to the store and buy a package of meat. And so if we were to take it, not only would we probably double or triple our uninsured rate overnight, but it would change the way insurers, right? So they've made decisions about which markets they're going to enter. And so now insurers may have to raise rates for other insured population. People may choose not to have those insurance because now the rates are going up and it may not be worth it. And so it would take probably a number of years to figure out what the full implications of that are, but it would be absolutely devastating to the populace as a whole, and especially for our low-income individuals.
Mm-hmm. So that would be bad then.
That would be bad. Oh, by the way, we created different ways of organizing healthcare. And so if you're talking about taking the entire law and changing it, now you've got all these other things that are not just the ACA exchanges and insurance that are tied to how we do things that are, again, how physicians get paid. And that's not the only law there, but it's a big piece of it. and who offers insurance, and there's a lot of components, and do we have electronic health records, and we have incentives for having those that would go away, and there's a lot of devil in the details, but it would absolutely devastate our system.
So like one of those dominoes in the system is, and I don't know but like I know I've been reading about the nursing shortage and how that's becoming a major issue. Would that be another, like things like that maybe you wouldn't think specifically are connected?
Yeah, exactly, right.
Down the road, like we could amplify an already major problem.
Yeah, absolutely. It's going to change. It's going to change the entire makeup of the system if you just. Now, again, that's not to say that you couldn't improve it, or you couldn't get rid of it and replace it with something better, or even something worse that's not devastating, right? Like, It's not like this is the only system we could have, but you can't just repeal it without something to replace it.
You need more than a concept of a plan. Like the concept of a plan is not the best quote from a debate ever.
But I wouldn't accept that from my students. So I'll put it that way, right?
So then on to the next question. It's kind of like more the other side of it. And, I'm asking, what about Medicare for all? But related, like anything, like any kind. I think that a lot of time we get caught up into, like Medicare for all when we're really talking about single payer, and there's different ways of executing single payer.
Yeah, absolutely.
So just in general, and for, like the people that are listening, what I mean is just there's like socialized medicine means that the government runs the hospitals and the doctor's offices. Single payer is kind of the government pays for your hospital bills, but the hospitals remain private. And so single payer is the government is the one that makes that pays the hospital to do your health care. You don't, it's indirect, or, you don't pay for it. The hospital does. And then you pay for your care through your taxes. So that's kind of like Medicare for all, and all these different variations of it are all basically the same thing. The government pays your hospital bills. It doesn't administrate the hospitals.
Sure. Yeah. I mean, there's difference in systems, and we could think about different ways. But okay, let's think about the government as the single payer, but not so. In England, the National Health Service, doctors are government employees, right? They work for the government. And you could think about in our country, that's like if we took the VA or the military health system and just expanded it, where everyone's getting government care. But we're not talking about that. We're talking about the government taxes people and uses it to pay healthcare bills. So everybody has something akin to what's now Medicare. But you're right, the devil's in the details, and there have been multiple plans that are put forward over the last few years. The most recent one was Bernie Sanders, who wants to say no co-pays, no deductibles, which is completely infeasible.
And that goes back to what you were talking about before, where people have like what was the word you used? Anyway, where people could just kind of abuse the system anytime.
It's called moral hazard, and again, like it's a little bit complicated, like from a term in that it has nothing to do with morality, right? And even abusing the system might not even be the term I would use, because again, there's nothing like if you tell me I can go use this care, I'm going to use it because I want to I'm trying to take care of me and my family. Mm-hmm. And so it's not that an individual is wrong to do this. It's that when we think about aggregating across individuals, it bogs things down. Right. And so this is not like, it's the difference between these like individual incentives and group incentives. And really we got to think about, okay, so let's say we did make it completely free, right? Mm-hmm. Like this is sort of the most recent Bernie Sanders proposal, along with others, though I can't recall who else was on that bill. Well, we don't have the infrastructure again to support that. So let's like even put away cost for a second, and it would be cost prohibitive. But just think about like the number of hospitals, the number of doctors. We already are facing both a doctor and a nurse shortage. And so now you're going to have people coming in that probably don't, like from a medical necessity, need that level of care. And so you're going to have a major issue with clogging up the system, longer wait times. Now, again, that's not to say that these problems aren't solvable in the long term, but in the short term, it's going to be very hard to do this. Now, what I will say is these would be very, very cost prohibitive to get to this level of a system. This Congressional Budget Office has done some estimates, and we're looking at somewhere around 30, 34 trillion, something like that, over the next 10 years if we were to do
But
this.
how does, like, the one thing, so if the government, I don't know if this is the right way to ask it, but hopefully you'll be able to make sense of it. If I'm spending that money in my taxes instead of on my premium, so
it's way more. It'd be way more than what you're spending on your premiums. Right. So think about something like 2 to 3 times what you're spending on premiums in order to fund it. And part of that is because of this moral hazard where people use more care once they have it. And then also, like, how we think about, right, like a lot of the discussions, oh, well, we save all these administrative costs. And that's not wrong. We would save some administrative costs, but it's not nearly enough to offset the additional costs that you would incur by having to do this.
Would there be like,
so let me give you one more sort of story here to support this.
Okay.
When Medicare was passed in the 1960s, there's a study by Amy Finkelstein, who's a very, very famous economist, that looked and said, okay, well, what happened to costs after Medicare was passed? And she looked at both the sort of those who were eligible for Medicare, the age 65 plus, and those that were below the age 55 to 65. And what you see is both follow this like huge trajectory where they expand their utilization. Now, Medicare was designed at that time to help the older patients. But what happens is the hospital now has all these like new patients coming in. And so there's a lot of incentive to invest in new technology. And again, the technology companies know that there's all these new customers, so they are going to develop new technology. That's all great. But the doctors don't say, well, I have this technology, but it was designed for people that are age 65, so I'm not going to use it for the 55-year-olds. What you end up with is this huge increase in the use of different technologies. And again, does this prolong life? Potentially, right? Like this isn't necessarily all a bad thing, but it is very, very costly. And so, if we want to take on, again, this is just the CBO estimates and devil's in the details with lots of assumptions. But if we're going to basically, double the amount of money that as a country we're spending on national health expenditures, was really what that comes down to. Could we do it? Absolutely. But what are we going to give up for that? Right? Are we willing to give up some of the other things that we enjoy? Because we are a very wealthy nation. And again, that doesn't mean that every person is wealthy, but as a country, we are very, very well off. So if you tell me we can't afford it, I'm going to tell you we can, but what are we not going to buy? Like, what are we not going to do? Are we going to spend less on national defense? Are we going to spend less on other programs? Are we just going to tax more? Because there's trade-offs, like in many things, and then how are we going to train enough doctors? Because right now we face both a doctor and a nurse shortage. And so how are we
thinking about that I've been wanting to ask you this. Like, I think about like supply and demand, and if demand is lower than supply, then the whole basic principle of economics is supply will go up to meet the demand. But I also understand it's not going to happen overnight. Like, you can't train a doctor in a weekend. So would it have to be like, is there a way that we could look at what you're talking about where we just don't have the institution set up and kind of build it into the system so that we progress gradually?
Yeah, I mean, we could. I mean, again, so the sort of Econ 101 is that markets equilibrate, right? So supply moves up to meet demand, and you get this equilibrium. But as John Maynard Keynes said, in the long run, we're all dead, right? Like, so yeah, eventually this will happen, but it's a lot more complicated than that. And this is what you sort of, right? Sometimes people, okay, they take the Econ 101 and they think, oh yeah, we just need a free market solution. It'll figure it out. But it's going to take a really long time to figure it out, if ever. Yeah. And so could we build something in that we're going to train the doctors, we're going to build the hospitals, whatever else we need? Sure. I mean, it's all on board, right? We can do this. The question is, how much is it going to cost and over how long, and what are we going to give up to get there? And so when you say, is it viable? Sure, there's a way to do it. But I'm very skeptical that that's the best way forward for the U.S. Now, this is different. Like, I just want to give a little bit of a history lesson here. One of the
Okay.
reasons that you see these single payer systems in Europe is that this was sort of the opiate for the masses. So if you go back to 150 years ago, the Civil War notwithstanding, the U.S. was a very stable country, right? We were not really worried about a popular uprising in the U.S. That was very different in, say, late 19th century Germany or in England. And what we saw was that as leaders, really kings or whatever, czar, whoever it was, or Kaiser, sorry, were being sort of threatened, give them healthcare was sort of like just to get them, let them eat cake, right? Give them something so that they wouldn't uprise. And the U.S. didn't have that, so we never had that incentive to provide something like single payer, and that changed the historical trajectory that we were on. So in 2024, to go back, like you can't, again, it's putting things back in a bottle, right? We can't go back to 1890 and change the way we were doing things. And so, how would we create the system is a big question. Something else, right? So, if we need more doctors and more nurses, like the way that supply meets demand is that because people are willing to pay for it, you end up increasing the rates. People are willing to pay more, and this is how you get this equilibration. Suppliers enter the market because they know they can make more money. That's different in we have regulated prices in Medicare, right? Medicare says this is what I'm going to pay for this. And two, our doctors and nurses make a lot more money in the US than they do in Europe. So to give like a primary care physician, which is one of the lower paid medical specialties in the US, makes on average somewhere around $250,000 a year. Wow. In England, they get paid somewhere in US dollars between $70,000 and $100,000 a year, right? And it's a little bit more in like Germany or France, but it's not a lot more, right? You're still talking that the US, we're paying roughly double for a doctor, double, sometimes depending on the country, you're looking at triple for a doctor in the US that you do in some of these countries in Europe that have single payer systems. Nurses, same thing, right? It's about double nurse's salary in the US. Now it's much less. It's like something like $75,000 a year for a nurse, where it's something around like 35 or 40,000 in US dollars across most of Europe. And so like we're just paying higher rates for everything in the US than they are. And so are you going to say now, doctors, you make $70,000 or $100,000 in order to do this? Well, that's hard to do when you're also trying to get more doctors into the market. And never mind the fact that, again, like you said, you don't train a doctor overnight. And oh, by the way, it's really expensive to train a doctor because not only do you have to go through medical school, but you have to have a residency, right? And that residency requires another doctor sort of, right, training you. And now we're paying that person in the hundreds of thousands of dollars. And part of their time is spent training these newer doctors that are not making that kind of money, that are seeing patients, but each patient takes a lot longer because they need to check and make sure they're not doing something wrong.
And then could you, this is just me thinking out loud here. Is there a danger there that the hospitals, because they can pay the residents less, or the resident is the one that's doing the training, or who's being trained?
The resident is the trainee. So there's basically, we have an internship. So it's the first year out of medical school, you do an internship, and then you become a resident for some number of years, depending on what specialty you're doing.
Okay. So if you're paying the residents less money and they have less experience, and you're trying to treat more patients with less money, is there a tendency to want to hire more residents, and then you're overworking the staff guy or whatever, and
you can't do that.
You're getting less quality care because you're being treated mostly by residents instead of.
So you might worry about, so there's sort of two components to this. One, residency slots are controlled by the government. And so a hospital can't just choose that they want more residents.
Okay.
So they're limited, and residencies, even though they're not paying those doctors very much money, and again, we're talking, 50, 55,000. They're not these, when you think about doctors being highly paid, it's not for their residency. But the cost of a resident is much more than that because of the training requirements and the fact that, yeah, I see a patient as a resident, but then I have to go see my attending and check what I did, right? This is what I want to do. Do you agree? Do you sign off on it? It ends up being very expensive. So most residency slots are actually paid for by the government.
Okay.
Now, the way we do that is I would say I don't like it's not a direct system. It gets added on to Medicare payments for other things, and I don't think it's necessarily the best way to pay for this. But they're paid for by the government, and hospitals are limited in the number of residency slots. And this is part of the doctor shortage is that we don't have enough residency slots. So we actually have more people graduating from medical school than we do have residency slots. And we have not really grown our residency slots. We've done it a little bit, but not nearly enough to train enough to keep up with our doctor shortage. And part of that is just, it's difficult, right? There's politics to it, but it's also expensive. It's also, we want to make sure that residents are getting enough individualized attention from training. And there's, again, none of these things are like easy answers, right?
Right. You can't just double the number of residents and then keep the number of trainers the same because then the training goes down and so on and so forth.
Yeah. And we have the same problem in nursing, right? We just don't have enough trainers for the nurses in order to build the nursing staff. And these are problems that we've been facing for decades, but the policies to stop this should have been implemented decades ago. Right. And they weren't, or they weren't at a big enough level that we're really sort of facing this cliff now, and we've got to figure out what to do about it.
It seems like that seems to be our approach to everything. Put it off until it's too late.
I mean, what was it? I think Winston Churchill said something like, "The U.S. always does the right thing after it's exhausted all other options." Options.
Yeah, as we're about to lose the state of Florida due to climate change. And anyway, while the governor denies that climate change is real. All right, so but to go on to this is the final question, and I think it's a good one. Let's say you're the king of the world, or you're the king of America, and you can do whatever magic solution you want to solve the U.S. healthcare issues. What would you do?
Before you ask me this, actually, Kelly, can we talk a little bit about? I know we're running out of time, but on Kamala's Harris's.
Right. Yeah. If you want, somebody wanted to ask you about that too. So yeah.
Yeah, I saw that on Twitter, so I wanted to make sure that we talked a little bit about this. And I'll say that I'm devil's always in the details. Need to know exactly what a proposal is, and I haven't seen anything yet that lays out all of the details. But I'm a big fan of home healthcare, and I think it's on its surface, I think this is a great proposal. But it depends on what it's covering. So, we got to think about like, who does home health cover? So if this is like mom or dad or grandma or grandpa that needs help with activities of daily living, right? They're having trouble like getting dressed. Maybe they need help with their shower. Maybe they need someone to help cook for them. Right now, we're paying for this. We're just not paying for it explicitly, right? And this is what Harris was talking about with this like sandwich generation of primarily women, but it affects everybody, who are both caring for their parents and caring for their children. And this is nothing new. I mean, this has gone on as long as people have been there, right? Like you have to, right? Like lots of cultures took care of their elders, but it creates a tremendous amount of stress, especially in today's world where we've got majority of working age mothers that are also in the workforce, and they're trying to do everything. And so if I just did some like quick back of the napkin math, right? So don't confuse this with a CBO estimate. This is just my back of the napkin math that says, hey, the average home health worker is not a nurse. So understand that we're not talking about healthcare. We're talking about somebody who's probably got a high school education, maybe a little bit of training, that comes in and helps somebody, right? Maybe cooks them a meal, just does the little things that
does the laundry.
My parents without healthcare training, right? They're on average make about $20 an hour.
Okay.
Right? Sometimes less, sometimes a little bit more, but about $20 an hour. Let's say that you needed somebody for 40 hours a week. Now, typically home health aides come a couple times a week, maybe once a day. Like, we're not usually talking about 40 hours a week. But let's, for the sake of argument, say 40 hours a week, right? So now I can continue in the workforce. I don't need to worry about mom or dad while I'm gone, right? Somebody else can help them take care. At $20 an hour, 40 hours a week, that's about $800 a week, right? Well, what's the cost of putting that same person in a nursing home? Same person in a nursing home is now, granted, when they go to assisted living versus a nursing home, again, inputs to good health. We can think about sleep, nutrition, and exercise. And keeping people at home is going to help both those, right? So if someone's helping with your meals, you're going to be a little bit more comfortable because you're in your own home, not in a nursing home. So maybe you're getting a little bit more sleep. If you're in your own home, you're more likely to get up, walk around, go to the bathroom, go get a drink of water. And so not only is for our elderly, is this potentially making them happier because now they're living at home, it's now reducing stress and probably helping sleep with the and potentially helping nutrition because, it's a little bit more time with the sort of the caregiver. And so I think there's a ton of benefits, and maybe we get higher tax base because people are not having to leave the workforce to take care of mom or dad. Right. So I think there's a lot of benefits that could be put into this model. Now, do we have enough home health workers? Absolutely not. Right. Anyone who's tried to go through this, and I just went through this with my wife's grandmother who recently passed. I'll say my mother-in-law went through this more like I'm just sort of hearing the stories, but getting a home health aide can be hard because we're in a world of something like 4% unemployment. And so how do you get enough workers, again, whether you're talking about doctor shortages, nurse shortages, home health aides becomes a problem, right? How do you get enough workers to do this? And that's, where I'm, a believer in broader, like looser immigration laws and bring people in that they can.
I was going to say, if only there were like millions of people that wanted to come here and get jobs, like.
Totally. Right. I'm a huge supporter of immigration. So, and I think that's really like, there are people that want jobs. They're just not in this country right now.
Yeah.
Predominantly. Again, not saying that everybody has a job, because I do know there are people that are out of work. But in general, we live in a world where most people who want to work have a job.
Yeah. What is 100% employee considered, like 5%?
Something like that. Yeah. That's a little bit out of my area.
Full
but
employment.
Something like that.
Yeah.
We're in a world of full employment, or just about full employment.
So that is actually really, so if I can recap, basically, it could cut the cost of the healthcare while increasing the quality of the healthcare for the patients if they're getting at-home care versus being put in a nursing home. So it's kind of the best of both worlds.
Now, again, like it depends on what the nursing home looks like, right? So having somebody come in and help you shower is different than having a nurse on call. So when we say increasing the quality, I think it depends on what metric you're looking at.
Right? Yeah, but I mean, just like you're just saying with sleep, like they can have a health, even just having somebody come in and cook meals and do laundry and do those things, even though they're not like, maybe they're helping administer some, make sure they take their medicines or whatever. But like they're not registered nurses or anything. They're just, like home workers or. My wife had a disability for a long time, and she had when we lived in Chicago, they had somebody like that. She came 3 times a week, 4 hours a day. She'd make some food, she'd do the laundry, and take care of, like if my wife needed to go somewhere, she'd take her somewhere. Took a lot of stress off of me. Made everybody's life better, including hers, because she had a job.
And again, I think there's a world, and again, there's so many details, and we really have to understand what the substitution effect is, right? When I say substitution, I mean, how many people don't go into assisted living or nursing facilities because of this? And so it's hard to say like this is cost saving or net neutral, but I can see, right, like without modeling it, I can see a model in which we believe that this is going to be cost savings rather than costing us money.
I had not considered that aspect of things at all. And I think it's actually, I think you sold me on it. Like, this is a program I could totally get behind.
I'm supportive. And again, once we see the details and have to have some modeling and see what we think those, what are the reasonable assumptions. And so I always sort of like try to caveat because, right, like, if I were to say, right, I did, this was like an hour of like work on it. If I spent 3 weeks working on it, I'd have to really think about
Yeah.
like what are these things and model it. But and the CBO will do their job,
Yeah.
hopefully.
And on
And
the
spend a lot.
political side of it, the thing that always annoys me about, oh, we need more specifics. And it's like, okay, the specifics, even if you have this microscopic detail in your proposed plan, a day after it gets to Congress, they're going to change everything anyway. Like it's like
Totally right. I'm not
what
blaming
gets
her for not
proposed and
having.
what ends up is always a totally different thing.
Yeah. But so typically, like when Congressional Budget Office, somebody's looking at this, they're going to have them some. Okay, so we think that 10% of people that would be in nursing homes are going to stay home. Okay, well, they're going to model, okay, what if it's 5%? What if it's 20%, right? And they're going to get a range based on these assumptions. And so what we really have to think about is like, what are the reasonable assumptions? And I don't, off the top of my head, I don't know what the reasonable assumption is.
Yeah, I hear
Now,
you. Yeah.
my assumption is that it's greater than zero,
Yeah.
right? And that because there's such a big difference in the costs, anything greater than zero could potentially be cost savings.
That makes sense.
But yeah, I think it's a very smart policy. But again, devils in the details, have to see what the proposal is and what would actually end up like getting through the political system. But I do think that there's a lot of value to what she has proposed. And again, like many things, if you can stop people before they get sick, it's better than waiting until they're sick, right? And nursing homes, like, right, people go there and you're around other people, but you're not, like, depends on how it's set up, you can be largely stagnant, and it can lead to people being sicker in a way that's not intended. It's just sort of the drawback, right? It's a trade-off of having to require this level of care. Now, again, there are levels, right? Every nursing home is not the same, right? We also have assisted living, which is not technically skilled nursing, but is a sort of stepping stone as you get there. And so lots of things to think about, but on its surface, I think that this is a great proposal.
So then, like just to move on to that last question, then,
Yeah,
you're the president with unlimited power. You've got a filibuster-proof Senate, and you've got the Congress. You can do whatever you want. How do you fix the system? Or how do you make it better?
All right, let me start off by just telling you that there are no silver bullets, right? And so this is something that my doctoral advisor would always say, and I agree with wholeheartedly, right? So we all want the thing that's gonna, create the best care for everyone and cut costs by 80%. Like, that doesn't exist. And so I know we talked about, I would like to put a link to listeners to what's called the 1% Projects for Healthcare Improvement. And this is a group of economists that have come up with a number of proposals that each they think would save somewhere 1 to 3% of healthcare costs, right? And the thing is that pennies make dollars, right? You save 1% here, you save 1% there, right? And these, a bunch of different policies that potentially. Okay, I'm gonna put that aside. So now I'm gonna talk about okay, so I'm the benevolent dictator, and what can I do? Or filibuster-proof majority that are gonna do whatever I want. So this is actually an assignment that I give to my students, or my executive students, to think about. And the way I do this is I actually present my plan after I let them present their plan so they can see how I would do this. And so I've actually thought a lot about this. And so I think about this in short-term, medium-term, and long-term strategies. In the short term, I would introduce what I would call reinsurance. So reinsurance is insurance for insurance companies, right? And these exist, but maybe not as much as we would like. And the idea is that an insurer, if you have a normal amount of claims, right, predictable, they're doing the insurance and they're doing the basically a transfer from healthy to sick. But let's say you get the crazy cancer that costs millions of dollars. Well, that's where the government comes in and now pays for it, right? And so what you're doing is you're limiting the risk, the downside risk to insurers, and that allows them to keep their premiums a little bit lower. It also stabilizes them, right? So things like I was talking about adverse selection, where you get these really sick people opting into insurance. Well, the really, really sick people are now, right, if you get that person, that there's basically a ceiling on how much you'd have to spend on that person. And so I think that would help really stabilize the markets, especially in the ACA, where they've had so much churn and not having enough access to the market. Second, I would introduce what I call negative coinsurance rates. I would say, what are termed negative coinsurance rates? And this is the idea that coinsurance is what you pay when you go to get your doctor visit. But actually, rather than you paying, the money's going to go to you. You're going to get, okay, so you go get your annual flu shot. Here's $20 or $10 or whatever we would need to decide is the right amount. Now, again, devil's in the details. How much would that have to be? Because depending on how many people get this, it could be expensive. But when we think about, okay, flu shots are one of the best things we can do for elderly people to prevent getting sick. And the cost of somebody who gets the flu, right, is potentially end up saving money. So negative coinsurance rates for the most valuable preventive care, as clinicians sort of debate what is the most valuable preventive care. And then economists think about like, okay, what's the cost effectiveness? We have things like temporary telehealth waivers that have been introduced. There's some politics to this, but I would make those things permanent, right? So I've done some research on hospital at home. So the idea is that after you get released from the hospital, you come to your house and you've got some stuff monitoring you. And you've got a team of like nurses that are monitoring a number of patients. And what this does is it gets people out of the hospital faster. I've done some research on this. What we've seen is that it's very valuable. And so I would make the temporary allowances regulatory permanent so that we can continue to invest in these types of programs. Because again, people tend to heal better when they're at home. Again, some of that's exercise, some of that's just like I get up to get a glass of water. If you're in the hospital, you ring the bell and someone brings it to you, right? Also, when you're in a hospital, and again, I was just in the hospital with my son, somebody comes in every whatever couple hours to check your blood pressure or your temperature. You've got machines beeping. You don't sleep well in a hospital.
Right. Yeah.
You go home, you can still be monitored and get a much better night's sleep, which is going to help your recovery. And so
how would
I
they
think
monitor things like, like your heart rate or whatever, like the things that are doing all the beeping?
Yeah, it's a technology. I mean, they're basically technology companies. They come in your house, they set it up. So they give you a bunch of equipment. A lot of it is just like wearables, right? They're lower profile than what you might have in the hospital. But it's transmitting data to a nurse that's monitoring a bunch of people like this.
So like I had an AFib for a while, and they are AFib, and they want after I had my ablation, where they kind of fixed everything. I had to wear this thing on my heart for like 2 days to monitor my moment. So it's like things like that, where it's like a wearable thing. It's not like they bring in, like the whole machine. They just give you this, and then
I mean, it depends on the model and what they're monitoring you for. But yeah,
okay.
I think most of it's pretty low profile. I mean, again, there's going to be people that need more, and there's going to be people that need less. There's a number of models. So my research on this had to deal mostly with COVID and with same day surgery for laparoscopic. Blanking on the name of the procedure, but it's basically where a sleeve gastrectomy. That's what it's called. Right. And so, these are very specific conditions. There's others that are thinking about postnatal care. There's some that are doing about cardiology care, some for chronic illnesses. So, what level you need really sort of depends on what it's being modeled for. But in general, this is, it's just like a wearable. You're not talking about bringing the entire like hospital into your house. It's just enough to monitor people, because a lot of what people spend time after, like, again, you're not talking about the immediate post-acute. But when you're in that hospital for that extra like few days, week, it's just monitoring, right? We're just making sure that something doesn't go wrong.
Yeah.
And often, it's not like you're talking about somebody all of a sudden like dropping dead of a heart attack where you need to have that doctor right in to come start like defibrillation. A lot of it, you might have some warning. You don't have a lot of warning, and you need to make sure that like the person's going to recognize that. And so having a nurse monitoring you can get that level that you need for some patients. Again, like, is every patient like, no, it depends on the right patients. You got to get the right. But I would, I think we rely on our clinicians to make that decision, right? I would say to make that recommendation. At the end of the day, the patient makes the decision, right? So next thing I would do is I would increase the scope of care of practice for our physician extenders. Physician extenders, things like physician assistants, nurse practitioners. This is debatable, right? So often these physician extenders are really good for things that we have a lot of diagnostic skill for, right? So if you have diabetes and you just need somebody to sort of help you and be your primary care, you may get the same level of care. And again, there's research going both directions on this, so I don't want to over state, but you might get the same level of care from a physician extender because all these great things that the physician learns in med school and through their residency just doesn't come into commonplace for many things.
Mm-hmm.
Now, their diagnostic skill may not be as good if you're like a new patient that has some sort of a one-off or a not as likely illness, then maybe the physician is better. And so, but for many patients, access to something is better than access to nothing, right?
Mm-hmm.
And so, you may say, okay, can you wait 3 weeks to see a physician, or would you rather wait 3 days to see a physician extender, right? And for many times, I'd rather get in to see somebody. Now, if they, a lot of times these people are very, very bright, right, and humble, and they'll say, okay, you know what, I don't know what this is. We need to refer you to see the physician.
Mm-hmm.
And
But
as
like
long
if
as they're
I
doing
just
that,
need a refill on uh, my blood pressure medication, I don't
yeah,
need to see a full-fledged physician like a PA or it's just
exactly.
fine to do that.
Exactly, right? And so, especially in rural areas, places with less access, this can provide access to care.
And does
Um,
that also by like make it free up the full physician to do
exactly,
only like to
exactly,
do the things that they can't do? Like,
exactly, right? We want everybody working at sort of the top of their license, right?
mhm,
So, just like we don't want the doctor, being the person that does the nurse's job, like, right, the nurse does their job, the doctor does their job, and this is just somewhere in the middle, right? That
mhm.
they've got a significant amount of training, they're able to independently provide care, but different states have different rules on this. And so, like, just by opening this up, you're going to allow like more people to have access to at least some care, and you're going to open up some capacity for physicians. Now, there's a lot of equity issues, right? So often if you're the Medicaid patient, you may only be able to get in to see the physician extender. Well, the person with the great employer sponsored health plan, sort of the Cadillac plan, only sees physicians. And so, there are some equity issues. But again, just sort of as a first one off, short term, I think opening up these scope of practices is going to be helpful.
And some of
Um,
these other like the physician extenders you're talking about, they don't take as long and they're not as expensive to train as a doctor,
Oh,
right?
absolutely. Yeah. Right. So it depends on whether you know exactly what the model is. There's PA versus NP. But you might think of this as like a master's level, right? So again, very highly skilled, trained people, but not to the same level of as a
Yeah.
physician. Um,
So so your plan so first of all you'd be mitigating the risk to the insurance companies so that more
mhm.
people can be insured, and
Yep.
then that also uh, allows higher risk people to be insured
Mhm.
without uh, making the insurance companies go bankrupt.
Mhm.
So that's how you would address uh,
Well, one more thing
uninsured.
on this,
Oh,
right? So there's one more. Well, there's really two more pieces, but let me start with.
okay.
I would also strengthen the ACA, so that means like states that have not expanded Medicaid would be forced to
Hmm.
expand Medicaid,
Oh,
right?
okay.
Right, which is going to be costly. Like, let's. There's
Hmm.
no bones about it, right? Now, the federal government's going to bear most of those costs, so it's not necessarily on the state, but it's going to be costly. Um, and I would increase. So I'm a little bit split on the mandate, but I would probably increase the mandate. Now, if I'm going to introduce a mandate, it's going to be expensive, right? It's going to be 25% of the cost of a minimal acceptable plan, which is basically what literature has said you need to get to full insurance.
Okay.
Um, you know, so and then the last thing here, right, is I would do a lot more focus on mental health. So we have some parity laws, but they're not very strong. So I would strengthen and enforce mental health parity laws,
What
which
are
just means
their
like
laws?
they're basically like whatever you're offering for I'll just say traditional other health, you have to offer for mental
Oh, okay.
health. And I would decriminalize and provide healthcare for minor drug offenses, right? We end up throwing people in jail when really it's a healthcare issue. It's not a crime issue.
Hmm.
Right. And this is maybe the one that's a little bit politically difficult, but I would allow involuntary civil committal for extreme mental health cases. Right. And so what this means is basically you can get somebody committed against their will if it's an extreme mental health case. I don't want to get too far into that because it's a whole nother conversation. But it's right, like we have a lot of problem with people that have mental health issues, right? Severe mental health issues that are just sort of end up in the homeless population rather than getting them the care they need. But getting somebody who's like already impaired to make the decision to get the care is very difficult, right? There's a big fine line. Well, it's not even a fine line, right? It's a really thick line here on how we're going to think about taking away people's rights, right?
Hmm.
Because that's what you're doing is you're taking away people's rights. And
Yeah.
so you got to be really, really careful with those kinds of rulings. But I do think that there's something is needed there.
Isn't there already like something there? Like
There is, but it's not very strong.
it's not there.
Um, it's not very strong, right? And what ends up happening is typically is that somebody with mental health problems will end up committing a crime and they end up in jail rather than like actually getting healthcare needs. Um, it's our like we've put a lot of like sort of like talking about mental health in recent years, but we haven't done a lot to actually like make it better, right? Like, I mean, so I'm a big believer that mental health is health, right? So that's why I don't like to sort of say anything other than like traditionally what we think about health, because this is a major issue going on.
So
Um,
I'm sorry. Just somebody has from on Twitter uh,
mhm.
said, no, the insurance companies can go bankrupt. I'm okay with that. How would you like there's this kind of a lot of people are not fond of the insurance companies and like
Yeah, I would
like
tell you that
why
if
would you
insurance,
why is there still do you think there's still a need for the insurance companies?
absolutely. So it's insurance companies have really been demonized in the press. And you can go back to things like Michael Moore had this documentary, right? Like Funeral at a HMO, right? And we go back to the 90s where they're denying care. Now, but I'm going to tell you that insurance companies lower premiums, or not lower premiums, lower costs of care, right? Hospitals are incentivized to charge as much as they can. Insurance companies want to pay as little as possible. And what a lot of people don't realize is that there are legal limitations on how much an insurance company can make. So this is under the ACA. Under the ACA, if you have an employer-sponsored healthcare, they must pay at least 85% of the premiums they collect on either payments directly to hospitals and physicians or to healthcare, or what they call quality improving activities. And quality improving activities is not a get around these are very auditable, right? These are things that are like symptoms, you're like that are really, or not symptoms, but programs to develop higher quality of care.
Hmm.
Um, the other 15% is split between their profits and administrative costs, whatever their administrative costs are. And so the average margin, it's hard to say exactly what it is, but it's certainly no more than 15%. It's probably much less than that, probably maybe 4 or 5% after
Oh
they
wow.
take their administrative costs in. Now, with the exchange market, it's only their what they call their minimum loss ratio is 80% instead of 85%. Maybe they have more administrative costs, hard to say. But you're not talking about that these insurance companies are making tons of money the way I think the press would have you believe. And again, look at your EOB and what a hospital's trying to charge versus what you're paying. Now, those charges are made up. If you didn't have insurance, they would not be that high. Part of that is starting a negotiation, but they would be significantly higher than what you're paying. And we see this. So places that have a monopoly hospital, right? So meaning that you have one hospital in an area,
Hmm.
they charge approximately 13% higher rates than markets where you have, say, 3 or more hospitals. Right? So hospitals are trying to charge higher rates. Now, they need to because of their I mean, again, there's all these other sort of complications, but in general, insurers are keeping those rates down. So, hey, the insurers can go bankrupt is sort of a popular comment, and I've heard that many times. And so, this isn't to denigrate whoever said that on Twitter, but you have to understand that they are providing value for you. And that it's not as simple as saying that the insurer is a bad guy. Now, it's much easier to demonize the insurer because that's not the face-to-face conversation, right? I see my doctor, I have a relationship with my doctor, I probably personally like them. The insurer is some pie in the sky, right? It's something that's telling me like what I can and can't do, or what's in my policy. And could we certainly make insurance companies better? Could we simplify plans? Could we, right? Absolutely. There's a whole nother conversation there, but insurers aren't necessarily the bad guy. There are good and bad actors across the spectrum, whether you talk about doctors, whether you talk about insurers, and sometimes patients, right?
Right.
Right? Like it's not so easy to say like this is the piece that, or pharmaceutical companies, right? Again, another one gets demonized. But again, without them, you don't get GLP-1s that for the first time in many, many years last year, obesity rates went down in the US. Well, that's probably due to the fact that now we have this miracle drug. And again, I say miracle drug, who knows what long-term impacts are, that's still TBD. But at least in the short term, really appears to work for helping people with obesity. But yeah, things are expensive. And there's ways that we can improve what we're paying to insurance or to pharmaceutical companies, but it's really hard to say that like this one group is the bad guy.
Hey, I have a question about some of that, and this is just layman question that's probably got an easy answer, but I've always wondered, like you're always contributing money. I've contributed lots of money to different, like heart disease or whatever, and so that money gets put into researching for these drugs that come up, right? And then they say that they need to charge that much to compensate for the cost of research and development. But if that money, what percentage of that money for research and development was actually from their own coffers versus what was donated by other people that wanted a cure? And then how honest does that make? We needed the money for.
If it was all free. What I'll tell you is that most of the money is coming from their own coffers. So first of all, I want to separate this, right? So they'll tell you you need to compensate me for the cost of developing this drug. That's BS. What you need to do is incentivize developing the next drug, right? That money's gone. Like you don't get paid back because you spent a bunch of money developing a drug. What you want to do is, so pharmaceutical companies are making a mathematical equation, right? They're saying that we want to make profits in the future. This is, again, we're a capitalist economy. We rely on profit incentives to get companies to do things, right? Whether you're pharmaceutical or anything else. And so they're coming up with a profit equation, and the profit equation is just, sort of the very standard. How much can I sell? What price will I sell it for? And how much does it cost? So, if I were to put this in a mathematical equation, I would say QP minus C, right? Quantity times price minus cost. And then you got to add in some probability here, because most drugs that a pharmaceutical company develop never make it to market, right? They fail either early or they fail in trials. They don't get the FDA. And so there's some probability. Let's say that 10% of what, and I honestly have no idea what the percentages off the top of my head, are going to make it to market. And so they're going to have to say, but they're going to bear some costs regardless of whether it makes it to market. And so they're going to do this complicated equation. And if they're not going to bring in enough money to compensate like this innovation, they're not going to do that innovation. What they already created is already there, right? They can't like uncreate what they already created. It's all forward looking. And so
just to make sure I understand what you're saying, like let's say they're trying to find some kind of cure for blood cancer, right?
Yep.
And so they've got like 100 different approaches to where they're looking at it, and 99 of them fail, but one of them works. So what you're saying is you can't just look at what it costs to develop that one drug that finally
Mhm.
worked and got approval. You've got to look at the cost of the whole 100, including the
Exactly.
99 that didn't work, because they were trying to find a solution to the problem,
Yeah.
not just that one drug.
Yeah. But even beyond that, right? Let's say they find the one drug that worked and they lose money on it, right? We come to the government, we say, we're the government, we're here to help. Give me the drug. You no longer have it. We're giving it at cost to people. And sorry, you lost money. That drug still exists, right?
Mm-hmm.
The drug didn't go away.
Right.
What happens is the pharmaceutical company says, we're not doing this. We're going to shift. We're no longer doing pharmaceutical research, right? Or we're going to do less. I mean, in reality, it's not going to be we just stopped doing anything. It's probably going to be we're only going to invest in really high probability stuff, which may have less
Mm-hmm.
value, or we're going to shift and we're going to focus on cosmetics instead of this, or we're going to put, we're going to spend, a little bit less on innovation than we would have. We're going to put less into R&D than we would have. And so what you're not going to get is the next big drug, right? So back to your question on the impact of donations. So let's go beyond donations. I'm not sure what percent. I would guess it's very, very little. But let's think about government funding, right? So this came up with mRNA, right? So we have these COVID vaccines.
Uh-huh.
And I've heard this, right? The government funded this. And then why are these companies making money? And I think what's important to understand is that the government funds what we call basic research. So basic research is what's out there, what's possible. This is stuff you're not going to get private companies generally to invest in because it's not marketable, right?
Mm-hmm.
We just sort of want to understand the world, right? This is the NIH with their spending, and they're doing grants often to scientists. As it works through the process, you get from basic research to applied research. This is where you get a lot of private money that comes in and says, okay, can we create an innovation that's going to solve a problem that we think we could bring to market? And then once it gets through the applied, then you get prototypes and all the other sort of steps to get something through regulatory processes and commercialization.
So if I understand what you're saying, like the mRNA vaccines, that like there was all this research that went into conceptualizing the idea of mRNA vaccines, but then COVID came along, and now it's like we need to see if we can make something like more than that's more than a theory. We need to see if we can develop an actual vaccine out of it, and so that's where you get in the applied stuff versus just the basic stuff.
Exactly, right? So these companies put a lot of money into it. Right now, the government also spent a lot of money, right? We guaranteed that we were going to buy a certain number of doses, even if it didn't work, so that we could incentivize them spending the money on it, or like offset, because otherwise they may not have. It might have been too risky for them. And so we, certainly the government contributed, but in general, right? Like private companies were putting money at risk by doing this, and not a small amount. Right. And that's what I think people have to understand. Like there's a big amount of money that's being put at risk. And the reason the mRNA had been developed but never taken off was there was no market for it. Right. So it had been developed largely thinking about like Ebola. But Ebola, there was a big outbreak in like 2014, but Ebola, one, just kills so fast that it doesn't tend to transfer as much. Mm-hmm. And going to Africa, right? That's not a market they can pay a lot of money. And so you ended up with sort of this like thought process, right? This basic research that was never really commercialized because there was no commercial application to it. And now, because of COVID, we're starting to think about, okay, well, what else could this be used for, right? But we had the COVID vaccine within like at least weeks of COVID getting here, maybe even faster than that. It was the regulatory process that took so long to get it to market. But we already had this, the basic science had been done. But companies, I mean, clinical trials are really, really expensive to run. And the FDA is really expensive to get through. Now, for good, some of this is good reason. We want to have strong regulatory that prevents harm to patients. But at the end of the day, like these companies put real money at stake, and they wouldn't put that money at stake if there wasn't a profit motive. Now, how we think about that may be different. Like there's other models that we could do. But I'm a fan where, and if I think about like longer term changes, I'm a fan of what we think about as you can think of it as a prize or a two-part patent, but basically you say, okay, you developed this drug. We're going to pay you this massive amount of money, and now we can offer it at low cost to everybody, right? So the company is potentially still making just as much money, but they're getting it in one fell swoop versus like at the point of entry. And now, again, how would you fund this? You got to think about taxes and other things. But at the end of the day, you still maintain that profit motive for the company. And the other thing I would do is I would tie that to some sort of effectiveness, right? So one of the ways we measure effectiveness is in quality adjusted life years. Now, this is not perfect, but we say, okay, you come up with the miracle drug, it adds on average, let's say 10 years of life to somebody. Or there's, I'm blanking on the name of them, but we came up with these great treatments for hepatitis C, right? So you may remember this in the last 10 years, hepatitis C went from being a chronic illness that's going to kill you to curative, right? We have a drug that'll cure it. Now,
I didn't know that, yeah.
Yes, we have a drug that will cure it. It right now costs something around $25,000 a dose. But it's curative, right? It's much less than having to be on a
worth your life,
right? If we say, okay, well, this is curative, we're going to give you whatever, say $25,000 a dose times however many doses we think that we're going to need for the population. Here's a set of money. Now you get the 17th version of the statin that doesn't really add a lot, but maybe instead of taking it once a day, you take it once every other day or something. And okay, it's an innovation, but it's not really adding very much. So we're not going to give you as much money for it. And what it's going to do is incentivize sort of these like path breaking, right? Like research versus the sort of easy stuff. That's not as big a deal and is not going to create as much value for the patient. So
I have a question about this that's related to this, and that's when it comes to like vitamins and supplements and things like that. On the one hand, it's like a really, really unregulated industry where nothing, like this stuff is not really vetted or tested well. On the other hand, there are things that actually help, and because it's not vetted, so you can. Like sometimes people can buy snake oil, but also sometimes people can like not recognize a valid treatment because of all the snake oil. And there's like, but the pharmaceutical companies have no vested interest in researching it. So what can be done about that? Because I think there is a place for like just supplements in the healthcare industry, but I think it needs to be like regulated, but there's no incentive to regulate it.
Yeah, so you'd have to think about that's a little bit of a complicated question because you don't want, if you made first of all, most supplements don't do anything, right? Let's be right. Most supplements don't do anything. And so do you want to regulate that market or do you let people sort of decide for themselves is an open question. If it's not causing harm, right? That's because what's for the ones that do work, do you rely on sort of word of mouth? Do you rely on the patient experience, or do you rely on going through the FDA? The FDA is a very, very complicated and expensive process. And so let's say you have the supplement that does work. Are you going to require clinical trials, right? And all of the aspects that go in it to go through the FDA process. If there's money to be made on it, right? If getting that FDA sort of seal of approval and putting it as a medication rather than a supplement has enough money in it, companies will do it. The question is, right, like, what's the mechanism? What's the patent? Like, how do we think about the intellectual properties of that? Because the supplements can be easily replicated, right? It's the reason that we give patents is that once you create a drug, it's very easy to replicate it, right? The actual cost of producing a drug is all in the innovation. It's not in the sort of the bioproduction facility. And so how do we think about then limiting, right? You'd have to offer like a patent protection for it. And so it's a complicated, I would say that if you think that you have the supplement that really does save something, that do something, you're probably going to think of it more on the drug side. Now, is it a molecule? Is it like some of this has to do with like mechanisms,
Mhm.
right? And so you'd think have to expand like what is the definition of a drug, and so there's a much more complicated like regulatory thought process on this. But we don't have that. We'd have to sort of invent how we're going to think about the intellectual property and the patents on these kinds
Yeah.
of
Because you can't
because
like
without
patent
that,
vitamin B or something like that.
yeah, right. It's I think it's yeah, it's not a very well functioning market because there's so many sort of false, or I'll say like placebos on the
Yeah.
market.
Yeah.
Just out of I know we're running low on time, but like so this you said snake oil. I just want to like when we think about like what we're paying and why the FDA, keep in mind like if you go back to like the 1920s and the 1930s before the predecessor of the FDA existed, people literally sold snake oil, right? It killed patients. Like
Mm.
like the reason that
Yeah.
we talk about snake oil salesmen is just people would make their tonic or whatever as a drug that was literally snake oil.
Yeah.
Um,
Yeah. And that's like
um,
the a lot of the homeopathic medicine is rooted in like literal snake oil.
yeah,
Um,
yeah.
which anyway, uh, yeah, there's a reason to regulate. Of course, I wouldn't mind some of that cough medicine from the 20s.
Well, be careful because what was I just reading about? One of these I can't remember if it was what it was treating, but it basically caused kidney failure, and like
Oh
this was
my.
really what caused the FDA to come about is because of like 100 people died because whatever soluble thing to help with, I want to say it was with tuberculosis, but I might be off. Basically caused kidney failure.
Wow.
So yeah, you had to be yeah,
But
it's yeah, and just at a just a note, if you look at uh, the problem. So in Europe, they gave a medicine for morning sickness to women in, I want to say the 50s, 60s, thalidomide. And it ended up causing all kinds of birth defects um, and infant mortality or stillbirths. And the US was basically immune to this problem because of our FDA that prevented this drug from ever getting to the market in the US. So we can argue about like, is the FDA too stringent? Is it too costly? How hard is it to get something through? And are there ways of streamlining that? But having a regulatory environment that can make sure that things aren't going to kill you or cause your babies to die is pretty important.
so okay, yeah, I mean, uh, thank you for joining me.
Yeah.
This has really been a productive and informative talk. I don't know if you've noticed, but we've gotten to around about 500 people listening for the last
Oh, wow.
hour. Yeah, so we've had a pretty good audience. So thanks again for joining me. And if you said, did you have a link that you wanted to send me?
So there's a couple, right? So I'd like to send you to the 1% Project for Healthcare Improvement. That's probably the key one that I think people might like to check out. And then if I think of anything else, I will. That's the one I'm thinking about right now.
So okay, yeah. If you send, I'll post that. Both there should be a Twitter link and a YouTube link. I'll post it to both places. And if anybody wants to follow you on Twitter, or do you want people to follow you on Twitter?
Yeah. People are welcome to follow me on Twitter. What am I at? I think I'm at SD Schwab. Let me might need to check that.
So you're
I'm either
you're an
yeah.
SD. You're not an HD Schwab. You're an SD
No.
Schwab.
Yeah, SD Schwab. So yeah, if you want to link to me on Twitter, people are welcome to follow me. And no, I've enjoyed the conversation. So thanks for having me.
Thanks a lot, and we'll talk to you later. Bye.